En el marco del esfuerzo continuado que viene realizando el Consejo en la prevención del cáncer oral.
The Council for the Prevention of Oral Cancer is making, and that encompasses this training course. I have the honor of presenting Mr. Mignogna to you. He is one of the most well-renowned figures in this field, as you probably know. And we're going to hear him tell us about oral cancer screening, 5 minutes to save lives.
Hello to everybody. I will have a speak of 25 minutes because I have the plane at 9:30, so excuse me. Thank you to Pedro and Juan for inviting me, and thank you to all the colleagues of Santiago. The first time for me in Santiago. I found a beautiful place and a very, very warm hospitality. Thank you very much. Well, I come from Naples. It's a beautiful city, hotter than Santiago for sure. It is summer now in Naples. And this is my university. I try to find the laser just a second. Well, it's the up. Parte final. Oh, on the bottom. The other side. Okay, at the end. Sure. And this is my university. Is a very old university, founded in 1224, and is the first public university in Europe. We are still now a public university. We treat a lot of patients for free, and we are very proud of this. This is the old building in Naples. This is the medical town in the high part of the city, on the hill. This is my outpatient clinic, and this is my group, my PhD Stefani Leuci, and another PhD Giulio Fortuna, now in US. My clinical assistant, Elvira Roppo, and Daniela Damo. I would like to thank them very much for their support. Well, this is the easiest part of my presentation. After this, I sat in front of my computer and I thought, what I have to say? Because I have prestigious colleagues that already talk about risk factors, PMD, and diagnostic tools, and clinical features of oral squamous cell carcinoma. What remains to say? So I think a little bit, and I think I can speak about open questions, because we have a lot of open questions on this issue. Which factors are behind the diagnostic delay, as you heard from Saman and other speakers? Why the diagnostic delay remain disappointingly constant over decades? And it is possible to identify patients with an increased risk to have cancer, and it is possible to reduce cancer morbidity and mortality with recall programs or screening programs. Let's take a look at what we know. These are WHO documents. We know that we can reduce through screening programs, screening strategies, we can reduce cancers for 2020 of 1/3. We have a predicted incidence of cancer of 15 million of new cancers. We can avoid 1/3, 5 million, from now to 2020. We know that the preventable cancer are those associated with tobacco smoking and infection. And oral cancer is one of these cancers, is among the malignancies that would best benefit from this approach. And we know that it affects an area of the body that is easy to access for clinical inspection and is preceded by long-lasting mucosal changes. And we know very well today risk factors. When we talk of screening programs, we talk about secondary prevention. We talk about a job that is placed in the first part of the secondary prevention when we have to early detect oral lesions. This data, this kind of structure for a national health program is take from the Ministero della Salute, is the Ministry of Health in Italy, and are the requisite of a national screening programs. Must be a qualitative controlled process that involves different healthcare providers. Is very important the equity of the project and the positive, negative effects of all the visits we do. Costs should be carefully monitored. Patients should have detailed and understandable informations. And we need to have incontrovertible epidemiologic data on incidence, prevalence, risk factors, mobility, mortality, and about costs. Well-known epidemiology, data available, we need RCT. RCT are randomized controlled trials, are scientific works that give evidences to medicine, and these evidences are now available only for 3 cancers and for 3 screening programs and for 3 screening methods: cervical smears for cervical cancer, mammography for breast cancer, occult test and colposcopy for colon cancer. We do not have this evidence for lung cancer, for example, for oral cancer. Not enough data on clinical outcomes of screening programs and on what happened in hospitals. We have no RCT. So I quite agree with the recent literature. We have in the literature other published papers on screening programs. We have 16 oral cancer, pre-cancer screening studies in Europe in the last 30 years. The largest is in Sweden, about on 20,000 patients. Also 11 in UK, 1 in France, 1 in Italy, 1 in Hungary. But if you take a look at the literature, you read that, and this is a paper from the Journal of American Medical Association of May 2013, very recent, that current evidence about the benefits and risk of screening for all cancers in asymptomatic adults is insufficient. I quite agree with this conclusion. We do not have enough data for a national health-based screening program. But we know something, we know that visual inspection is the right method to look at oral mucosa, like mammography in breast cancer, like PSA for prostate cancer. We know that visual inspection is a good technique for oral cancer, WHO documents. And that early detection saves lives. And in particular, early detection we have evidence in the literature that early detection is a good method in higher risk individuals. This is the RCT from the Lancet 2005 with a huge number of patients examined, I think 18,000 maybe, very, very high number. And we know that, so screening we know that on-risk individuals could be a good method. But if you perform your screening only on high-risk individuals, you can lose patients. What about, for example, HPV? How can we detect HPV patients and to perform a screening in these patients? For us, the answer that the screening must be opportunistic during daily activity in the dental field and in the medical field. Oral cancer is ideal to identify patients by screening, to identify these forms by screening, because it is frequently preceded, more than 50%, by an identifiable premalignant lesion, and the progression from dysplasia occurs over a period of 2.5, 8 years. It's a very, very long period. But we have a number of early diagnoses that it is quite similar to that of a colon cancer, 36%. These data are stable during the last 20 years. There are a lot of reasons. You heard from my colleagues during the afternoon how many points are to be considered. We have to consider it. But the most important for us is the lack of education among dental and medical professionals, and the absence of prevention and detection by healthcare providers. This is a major issue. Dentists have high capacity to explore oral cavity with low costs. High costs maybe from a psychological point of view. They spread all over countries. A large part of the population undergoes dental treatment. They are a very good filter in order to exclude dental disease and or reactive process. This is advertising from the American Dental Association. It is tiny now. Don't let it grow up to be an oral cancer. This is the reason of the Leonardo project, as you heard before. But also in Italy, we have projects with dentists to improve the skills of our dentists to visit and detect oral cancer. The project is 5 minutes to save life, 5 minuti per salvare una vita in Italian, with the ANDA, Associazione Nazionale Dentisti Italiani. This is the logo of our Oral Cancer Day every May every year in the month of May, and is a national project. It's very interesting as structure because we have a phase 1, first year, a phase 2, second year, and the phase 3, the third year. Phase 1 is for free, phase 2 and 3 are for a fee, 30 euros, very low fee, just to motivate colleagues. We have tests between the modules, 70% of the correct answers to pass to the second stage, and the candidates can download papers, documents for free during these stages. Take a look at phase 1. We made phase 1 in 2012. Module 1, background. 2, risk factors. 3, primary prevention. 4, counseling on smoking cessation. 5, informative materials for the dental office. 6, model of primary prevention for the private practice. 2 very important modules. The results, 6,000 participants among Italian dentists with a very low dropout. The dentists that are associated with the ANDI are 13,000, so almost 50%. Phase 2, this year, module 1, basic alterations of the oral mucosa, clinical part, pre-cancer and oral cancer. And next year, in 2014, we will have phase 3 with work groups, clinical simulation, clinical training in stages in every Italian region. All the Italian colleagues will work with me, almost one in every region. We will contact all the dentists that are involved in the project. We will have frontal lessons almost all over Italy. Well, but another question is how to teach. In the pre or postgraduate, continuing education, how we have to structure courses, web-based, local meetings. It's not easy to give an answer to these questions. We are trying to have feedback from experts, scientifically, with some web-based methods such as the Delphi method. We are trying to understand what is the best way to teach to dentists and to general medical practitioners. But I would like to tell you what is my opinion. I like very much the sea and boating, and this is one of my favorite quotes of Saint-Exupéry. If you want to build a ship, don't drum up people to collect wood and don't assign them tasks and work, but rather teach them to long for the endless immensity of the sea. Well, I think it's just the same for our medicine. One of the most beautiful disciplines in dentistry, but maybe also in medicine. We have to teach, for sure, PMD. But I think we have to teach in the pregraduate courses in our university during the dental course that oral medicine is part of a dental training, like periodontology, like orthodontics. Dentists have to know that oral medicine must be in the dental office, and we have to teach clinical morphology and topography. We have the strength to identify what we are looking at. As someone told you, you have to describe the lesion. White patch, red patch, margins, induration, inflammation, ulceration. Morphology is very, very important. We have to teach that we have papular lesions, keratin, what is atrophy, what are these erosions or ulceration, fibrin. So we have to look at the morphology of the lesions, erythema or ulceration, if they are indurated or not indurated, bleeding or something else, or bullous lesions. You know that bullous lesions has to be detected clinically and has to be diagnosed with also histology and immunological techniques. But there is a clinical method very useful to identify bullous lesions, that is Nikolsky sign. Also in bullous lichen planus is very useful. I prefer to use this kind of instrument. It's very easy to understand that you are looking at a roof of a bulla and that this is a detachment. White patches, homogeneous, non-homogeneous, if there are ulceration, and to understand histology, to properly read a referral from the anatomopathologist. Gingiva, it's very easy for the dentist. It's quite impossible for a general practitioner, medical general practitioner. Or red lesions, dysplastic or non-dysplastics, infected by candida or not infected, erosions, keratin, speckled lesions. Try to describe the morphology of what are you looking at, or pure red lesions like in this case. Plaque, reticular, at the margin, in red, erosions, in yellow, ulcerations. Erythema, bullous lesions in the case of a lichen planus of the buccal mucosa with the immunologic mediated process of under the basal membrane pigmentation. Verrucous lesions, homogeneous lesions, or almost everything. Here we have verrucous hyperplasia, carcinoma, verrucous carcinoma, squamous cell carcinoma, homogeneous leukoplakia, high-grade dysplasia, almost everything in this case of a field cancerization. Topography. Also topography is very important because if you have erosive lesions and you have this kind of topography, you understand it is an infectious disease. And if this part of the oropharynx is involved, maybe could be a Coxsackie infections. Or the palate. Topography. If you have lichenoid lesions only on the palate, check for systemic diseases such as systemic lupus erythematosus. Or prone cancer site, like the ventral part of the tongue and that's for the mouth. An isolated lichenoid lesions of the ventral tongue in young men is a very, very dangerous lesions, also without dysplasia. But it's important also to look at the site, the dimension, the local interaction. This is very important for dentists. Gingiva. Look at the papilla and the gingiva, or the lingual site, not easy to see, or where are the incisors, lower incisors. This is a typical dental site. Or a frictional reaction. This is a frictional keratosis of the gingiva, not too big. This is the lesions that we have to identify. These kind of lesions. Look at these lichenoid lesions of the gingiva. Keratin, a reticular shape with micropapillar shape, and there is erythema here and a slight atrophy of the papilla. Also in this case, this is a lichen planus of the gingiva. You need a good eye, and I think you need to be a dentist. This kind of lesions. This is a plaque-related lichenoid lesion. Other cases of gingival lichen planus with very few lesions, like here. Bigger lesions, let's go. Or reactive lesions. This is benign alveolar ridge keratosis, or also reactive lesions of the buccal mucosa, but you have to make differentials because you can have a verrucous leukoplakia or a retroleukoplakia with similar aspects of the frictional type. This is a frictional lesion, this is a frictional lesions, cheek biting, or reactive traumatic lesions of the tongue, or HPV manifestations of the oral mucosa. These are the HPV-related lesions, not cancers, but related lesions. Squamous papilloma of the tongue, squamous papilloma on the floor of the mouth, warts, or acuminate condyloma, or more rarely the flat condyloma. I do not use Valscope or Visilight. I use only toluidine blue to identify not the lesion, but the site that I have to biopsy. Look at this case. This is the lesion, this is the blue, but take a look this site. Severe dysplasia and cancer, invasive cancer here. Well, early cancer. This is a leukoplakia with an early cancer in this place. Bigger on the buccal mucosa, early invasion. Bigger with areas of erythroleukoplakia with speckled aspect in the anterior part of this buccal mucosa. So you have to look at the gingiva, at keratin, plaque, try to figure out if it is a leukoplakia or a multifocal leukoplakia and not to cancer of the gingiva. Look at your alveolar ridge with this verrucous keratosis. You have to detect, you have to biopsy, you have to follow the patients, you have to treat, you have to talk to avoid invasive cancer. Multifocal leukoplakia, or if you want verrucous leukoplakia, proliferative verrucous leukoplakia. This is the evolution. Look at your palate. Erythema, erosions, keratin, to avoid cancer. Leukoplakia of the gingiva, cancer of the gingiva. So put on your gloves, take your goggles, take your light, your heart, your brain, your eyes, 5 minutes of your time to save lives. Thank you very much.